Usually when we talk about surviving a major illness like breast cancer, there's this cultural expectation of just pure victory.
Oh, absolutely. It's treated almost like a binary state.
Right. You imagine someone crossing a finish line, ring that brass bell in the oncology ward, getting the all clear on the scans, and then just seamlessly returning to their normal life.
Yeah, you went to war with the cancer, and now you don't have it anymore, so society expects a completely clean break and a happy ending.
But reading through the stack of medical literature we pulled for today's deep dive, that clean narrative shatters pretty quickly.
It really does.
Because when you step into the real world of cancer survivorship, the post-treatment landscape is honestly brutal. For millions of breast cancer survivors, beating the disease comes with a massive, hidden tax on their bodies.
It is the absolute definition of a medical catch-22. To survive the cancer, the treatment essentially forces the patient's body into a sudden, severe, medically induced menopause. And one of the most devastating yet honestly least talked about consequences of that is the profound degradation of their intimate health.
And that's exactly what we are focusing on today. I want to welcome everyone to the deep dive, and our mission today is to figure out if we finally have a viable primary regenerative option for these women.
Yes, a non-hormonal option.
Exactly. Specifically, we're looking at something called polynucleotides and whether they can reverse this severe tissue damage. Because right now, looking at the sources we have on the desk, clinical trial data, the ACOG guidelines, real-world case series from OAText, and clinic FAQs, the standard of care is leaving a lot of people behind.
The gap between what these patients need and what they are traditionally offered is just staggering. But to really understand why a new biological treatment is making waves, we kind of have to look at the trap these survivors are caught in.
Let's get into the mechanics of that trap. In the clinical guidelines we reviewed, including the latest from the American College of Obstetricians and Gynecologists, they refer to this condition as genitourinary syndrome of menopause, or GSM.
Right, and more specifically within that, vulvovaginal atrophy. Basically, when a woman's estrogen levels plummet, her vaginal tissue physically breaks down.
But for breast cancer survivors, this isn't, a gradual natural transition over several years like natural menopause.
No, it's an abrupt chemical cliff. Therapies like aromatase inhibitors or tamoxifen are foundational to breast cancer treatment. Their entire job is to aggressively starve the body of estrogen.
Because the estrogen is feeding the cancer.
Exactly. In about 80% of breast cancer cases, estrogen is the exact fuel that feeds the tumors. So you have to shut it off.
But estrogen is also doing a lot of structural work in the body, right? I was looking at the real-world case series data, and the estrogen is essentially the manager that maintains the thickness, elasticity, and lubrication of the vaginal and urinary tracts.
Yeah, it keeps the whole system resilient.
So when you shut off the estrogen supply with these cancer drugs, the data shows a staggering loss of up to 75% of type I collagen in those tissues.
And 75% it's a catastrophic structural collapse at a cellular level.
Oh, wow.
The tissue transforms completely. It becomes incredibly thin, fragile, pale. The natural folds in the tissue, the rugae, they flatten out entirely, which just destroys the elasticity.
And the resulting symptoms are severe. We're talking about intense dryness, burning, itching, chronic urinary tract infections,
Yeah.
and debilitating pain during sex, which the medical literature calls dyspareunia.
What's agonizing? Women are fighting through the trauma of cancer only to be left with chronic, severe pain in their most intimate areas.
It seems like such a cruel irony.
And the real tragedy of this is how often it goes unspoken.
Yeah.
Many women endure this in silence, believing it's just, the inevitable price they have to pay for surviving cancer.
Just the new normal they have to deal with.
Right. But the physical reality is so bad that a significant percentage of women actually stop taking their life-saving estrogen-blocking medications.
Wait, really? They risk the cancer coming back?
Yes. They risk a cancer recurrence because the day-to-day pain of the side effects is just too much to bear.
Which brings us to the dilemma. The ultimate gold standard treatment for restoring this tissue is estrogen therapy. But as we just established, 80% of these breast cancers are estrogen dependent.
The medical consensus on this is incredibly complex. If you read the recent ACOG guidelines, they actually state that low-dose, localized vaginal estrogen is generally considered safe for many breast cancer survivors.
Because it's localized.
Exactly. The reasoning is that the dose is so small and it stays entirely within the vaginal tissue rather than entering the systemic bloodstream, so it theoretically shouldn't increase the risk of the cancer returning.
But reading the patient forums and the clinical FAQs from oncologists, the reality on the ground is completely different. Despite what the official guidelines say, many oncologists and the patients themselves are absolutely terrified of introducing any hormones back into the body.
And you can't blame them.
Not at all. Imagine you're dying of thirst in the desert, and someone hands you a glass of water, but tells you there's a tiny microscopic chance it contains a drop of poison. Even if a panel of experts assures you it's been filtered, your instinct is going to make you hesitate.
That is a perfect analogy. The fear is entirely visceral. I mean, a patient who just spent a year battling an estrogen-fueled tumor is naturally going to view estrogen as the enemy.
Right.
And because of that completely rational fear, the first-line recommendations from most doctors usually steer clear of hormones entirely.
So we look at these non-hormonal options. The immediate go-to recommendations are over-the-counter vaginal moisturizers, like Replens and simple sexual lubricants.
Yeah, the basic pharmacy aisle stuff.
But okay, let's unpack this. If a woman has lost 75% of her collagen, using a surface-level moisturizer sounds like putting a fresh coat of paint on a house with a collapsing foundation.
It's just a Band-Aid, right?
It's worse than a Band-Aid, honestly, because while the moisturizer masks the friction temporarily, the underlying cellular atrophy is actually still progressing because nothing is telling the cells to rebuild.
Exactly. You get a few hours or maybe a day of symptomatic relief, but the tissue remains thin, the collagen remains depleted, and the microtears in the fragile tissue just continue to happen.
Because of that massive gap in care, we're seeing medical science desperately testing other non-hormonal options to try and force the tissue to heal itself. I found the clinical trial data on this really revealing, specifically the attempts to use physical trauma to stimulate healing.
You're referring to the high-tech physical interventions.
Right. The sources mentioned the Revitalize trial, which looks specifically at using fractional CO2 lasers on the vaginal tissue of breast cancer survivors, which on its face sounds incredibly intense. Firing lasers into already fragile, painful tissue? How is that supposed to help?
I know, it sounds counterintuitive, but it relies on a concept called controlled microtrauma. The laser basically burns tiny microscopic holes into the vaginal lining. The theory is that this thermal damage shocks the dermal cells, causing a massive inflammatory response. This tricks the body into rushing blood, nutrients, and collagen to the area to heal the burns.
Which thereby thickens the tissue in the process.
Precisely. And the Mayo Clinic has been taking a slightly different route with their phase 1 trials. They've been testing platelet-rich plasma or PRP injections.
I read about that. They draw the patient's own blood, right?
Yep. They draw the blood, put it in a centrifuge to separate out the plasma that's rich in healing platelets, and then inject that plasma directly into multiple sites along the vaginal canal.
Because those platelets contain potent growth factors.
Exactly. By concentrating them and injecting them locally, the goal is to aggressively signal the tissue to regenerate and grow new blood vessels.
Okay, so both of these options represent real outside-the-box thinking, but they also come with significant barriers. I mean, they require specialized clinical visits, they can be quite painful, especially the injections into an already sensitive area, and they're often highly expensive and rarely covered by insurance.
Which leaves the average patient right back at square one.
Yeah.
They need something that rebuilds the cellular foundation from scratch without using hormones, but ideally without requiring a blood draw or an expensive laser procedure.
And that leads us to the core of our deep dives today. Since Band-Aids aren't enough, we need something that rebuilds the foundation. The sources highlight an emerging field of regenerative medicine focused on something called polynucleotides.
Yes. Polynucleotides, or PNs.
But I have to be completely honest here. When I first read the literature on what polynucleotides actually are, it sounded exactly like a wellness scam you'd see being peddled by an influencer on social media.
Oh, I know exactly why you say that. Because of the source material.
Right. The papers state that polynucleotides are natural origin, highly purified DNA fractions. And where do they extract this DNA from? The gonads of male salmon trout.
It is quite the headline.
My immediate reaction was pure skepticism. I mean, how on earth did rigorous clinical science arrive at rubbing fish DNA onto human tissue as a medical treatment?
It sounds totally bizarre until you look closely at the biochemistry. Scientists didn't just pick salmon trout at random. The reason they use the gonadal tissue, specifically the sperm cells of the trout, is because those cells are essentially pure, tightly packed envelopes of DNA.
Oh, so it's just an efficiency thing.
Very much so. It allows for a highly efficient extraction of the raw genetic material.
But why fish and not, something closer to humans?
Because salmonid DNA is remarkably compatible with human biology. The base pair composition, like the specific ratio of the molecules that make up the rungs of the DNA ladder, is incredibly similar to our own.
Okay, that makes sense.
Furthermore, because it's a completely different species, it lacks the specific mammalian proteins that typically trigger an immune response or an allergic reaction in humans.
Ah, so your body doesn't reject it.
Exactly. Once it's hyperpurified, you are left with a biologically neutral, highly potent raw material.
So we have this purified fish DNA. The patient applies it to the vaginal tissue, usually via a cream or a localized suppository ovule. But it doesn't just sit on the surface like a typical moisturizer. The mechanism of action detailed in the research is fascinating.
It is. So our bodies naturally produce enzymes called nucleuses, which are present in our tissues. When the polynucleotide gel is applied, these enzymes immediately get to work.
They break it down.
Yeah, they recognize the long chains of the fish DNA and begin to cleave them, chopping them up into much smaller nitrogen precursors, specifically nucleosides and nucleotides.
Which are the fundamental building blocks of all DNA.
Right. Once those raw building blocks are freed up in the tissue, they are absorbed by the local human fibroblasts.
And this is where the magic happens, structurally speaking. The sources explain that fibroblasts are the specific worker cells in our body responsible for manufacturing collagen and elastin.
Yes, they are the cellular factories.
But during menopause, because they've lost their estrogen supply, these fibroblasts essentially power down. They go dormant.
But flooding the local area with these nucleotide building blocks forces them to reactivate. It's a process called the salvage pathway.
The salvage pathway.
Yeah, the dormant fibroblasts realize they're swimming in premium, ready to use raw materials, and it kickstarts their metabolic engine. They begin churning out type I collagen again, rebuilding that extracellular matrix.
If we go back to the estrogen analogy from earlier, it makes perfect sense. Estrogen is the architect on the construction site, constantly shouting orders to the workers to keep building the wall.
A very demanding architect.
Right. And when the cancer drugs fire the architect, the workers stop working. Using a laser is like setting a fire on the site to panic the workers into moving.
Ah, that's one way to put it.
But polynucleotides are like silently dropping off a massive pile of premium bricks and mortar directly at the workers' feet. You don't need the architect to shout at them. The sheer availability of the raw materials triggers them to start building the wall again. No architect required.
That captures the cellular mechanism perfectly. You completely bypass the need for the hormonal signaling by supporting the cellular vitality directly. But there is a secondary mechanism at play that is just as important for the patient's day-to-day comfort.
Oh, the hydration factor.
Yes. Because of their specific molecular weight and structure, polynucleotides act like a massive biological sponge. When applied to the tissue, they organize into a three-dimensional gel matrix that actively binds and holds huge amounts of water molecules.
So you're getting massive immediate hydration at the exact same time the long-term structural rebuilding is kicking off.
Which brings us to the clinical data. The biological theory of dropping off bricks and binding water is elegant, but the medical community only cares if it actually translates to healing human tissue.
Right. And does it? I mean, if you're listening to this and you or someone you love is dealing with severe vaginal atrophy from cancer treatments, the only thing that matters is whether this actually takes the pain away. Let's look at the real-world evidence from the OA-TEX case series.
The OA-TEX cohort monitored 54 postmenopausal women who presented with severe atrophy. They were prescribed polynucleotide ovules. Gynecologists measured their tissue health before and after the treatment regimen, and the physical changes were drastic.
What were the numbers?
Vaginal hydration metrics improved by nearly 60%. Natural vaginal secretions increased by 52%, and the deeper tissue elasticity, the actual stretch and resilience of the vaginal wall, improved by over 50%.
But elasticity is just a metric on a doctor's chart. The crucial part of that study is how the women actually felt.
Absolutely.
The subjective reporting showed that symptoms like intense burning, constant itching, and dyspareunia, that severe pain during sex, dropped by over 70%.
And a 70% reduction in pain transforms a patient's quality of life. It takes them from suffering daily to regaining their sense of self.
But we have to be specific here. Those were postmenopausal women in general. Did the clinical data look specifically at breast cancer survivors actively going through chemical menopause?
It did. There was a dedicated trial conducted at the University of Naples. They focused exclusively on a cohort of 60 breast cancer patients who were actively receiving adjuvant therapy, meaning they were currently on the aggressive estrogen-blocking drugs.
So the absolute hardest test case.
Exactly. These women used a polynucleotide-based vaginal cream over a 6-month period. Gynecologists tracked them using the Vaginal Health Index, which physically measures moisture, fluid volume, elasticity, and epithelial integrity.
And they also measured the psychological side, right?
Right. They used the Female Sexual Function Index to measure the psychological and physical experience of intimacy.
And the results held up.
They saw highly significant improvements across both indices. The tissue physically thickened and healed, and the pain diminished. Most importantly, for this specific population, the researchers continually monitored their oncological status.
Right, because of the cancer.
Over the entire course of the study, not a single woman had to stop her cancer treatments, and there were 0 instances of cancer recurrence or interference with their life-saving medications.
Wow. But while reviewing that Naples data, I noticed a statistical detail that seems like a paradox. Here's where it gets really interesting for you, the listener.
Oh, what did you catch?
The research noted that over 60% of the women reported significant symptom relief within just 2 weeks of starting the polynucleotide treatment. But based on everything we just discussed about fibroblasts and the slow process of synthesizing new type I collagen, it doesn't add up. If this is about growing new collagen, how on earth is it working that fast? You cannot build a new cellular foundation in 14 days.
That is a very sharp observation, and it goes directly back to the dual action nature of the polynucleotide molecules we discussed a moment ago. The tissue is not structurally rebuilt in 2 weeks.
Okay, so where's the relief coming from?
That immediate window of relief comes entirely from the profound water-binding properties. The polynucleotides instantly form that 3D gel matrix, pulling moisture into the dry tissue and locking it there. It acts as an incredibly high-grade, immediate soothing agent and lubricant.
So it basically serves as a highly advanced Band-Aid on day one.
Exactly. The immediate hydration masks the friction and drops the pain levels, which buys the body the necessary time to execute the longer-term mechanism.
Buying time for the workers to lay the bricks.
Yes. The slow, steady regeneration of collagen by the reactivated fibroblasts occurs gradually over the following months, eventually replacing the need for the Band-Aid with actual healthy tissue.
So, synthesizing everything we've looked at today, we know polynucleotides effectively rebuild the tissue. We know they completely circumvent the danger of introducing hormones to an estrogen-dependent cancer survivor. We know they don't require a laser procedure. Returning to our mission for this deep dive, should polynucleotides replace the standard moisturizers as the primary go-to option for these patients?
Well, we are currently witnessing a paradigm shift in how survivorship care is managed. If you look at the most conservative global guidelines, they will likely continue to push cheap, easily accessible moisturizers and lubricants as step one, simply because of cost and availability. However, from a strictly regenerative and biological standpoint, PNs, which are often delivered via creams or ovules and frequently combined synergistically with hyaluronic acid for even more moisture-binding power, offer something traditional treatments cannot.
Actual tissue regeneration.
Exactly. For breast cancer survivors, especially those on aromatase inhibitors, where even a drop of estrogen is feared, PNs check every box. They are non-hormonal, non-pharmacological, highly safe, and address both symptoms and root causes.
And there are ongoing trials solidifying this position, right? Like trial NCT 054646464, which is comparing PNs directly to estrogen.
Yes, head-to-head against the gold standard.
But I have to offer a final pushback here. In medicine, we always want the massive, multi-center, head-to-head phase 3 trial data before we officially rewrite the global rulebooks. If those definitive trials are still ongoing, are we jumping the gun by calling it a primary option now? Should doctors be telling these women to just wait for the final published data?
From a purely academic standpoint, yes, you wait for the phase 3 data. But clinical practice involves human beings. If you have a breast cancer survivor sitting in an office right now whose quality of life has been decimated by severe vaginal atrophy and who is terrified of estrogen, telling her to wait 3 to 5 years for a trial to conclude is an unacceptable standard of care.
It's just cruel.
It is. Given the robust safety profile of these highly purified natural DNA fractions and the strong real-world efficacy we've already seen in the cohort data, polynucleotides represent a highly compelling first-line regenerative choice that patients should absolutely be discussing with their oncologists today.
If you are listening to this and you or someone in your life has survived breast cancer only to be sidelined by this hidden tax on their intimate health, the biggest takeaway from our deep dive into these sources is that the narrative is changing. Millions of women suffer these intimate side effects in silence, thinking it's just a normal part of aging or surviving cancer.
But it doesn't have to be.
Exactly. Knowledge of these regenerative options is power. You do not have to accept a collapsing foundation. We finally have tools that hydrate and rebuild vaginal tissue from the ground up without hormones.
Leveraging the body's own raw building blocks.
It's incredible. But before we wrap up, looking at the sheer biological potential of what we've unpacked today leaves me with a massive question about where this science goes next. And we want to leave you, the listener, with a final thought to ponder.
It opens a fascinating door, doesn't it? If applying these purified DNA fractions can so effectively trick dormant cells into waking up and rebuilding degraded vaginal tissue simply by flooding them with the precise raw DNA building blocks they lack, what does this mean for the future of human aging?
Because atrophy isn't just happening in one place.
Exactly. What does this mean for how we treat cellular decline across the entire body? Right now, the anti-aging industry is heavily focused on manipulating hormones to keep people youthful, which always carries risks.
Right.
But what if we could eventually bypass the risks of hormonal anti-aging therapies entirely? Could we one day just feed our cells these raw DNA building blocks across all our organ systems to keep them youthful?
Just keeping our tissues resilient, not by altering our chemical messengers, but simply by ensuring our cells never run out of the basic bricks and mortar they need to repair themselves. It makes the entire blueprint of how we age look a lot less permanent.